This is a 62-year-old male arteriopath who was referred to the vascular lab because of a loud right cervical bruit and multiple episodes of right-sided amaurosis fugax that persisted despite the initiation of aspirin therapy. Carotid duplex scanning revealed a heterogeneous plaque formation at the bifurcation, creating a 90 to 99% stenosis at the origin of the ICA. This is the sagittal view from that study, which shows a fairly obvious lesion right here at the bifurcation. This is the internal vessel here. That's the external vessel. This velocity waveform was recorded in the common. This was the proximal ICA. This is the distal ICA. The patient declined hospitalization at this time, but did return 2 days later and was anticoagulated with intravenous heparin pending arteriography. Selective carotid arteriography was performed in the afternoon on hospital day 4. A total of 6 days had elapsed between the initial duplex scan and arteriography. Physical examination, both at the time of admission and on the day of arteriography, confirmed the presence of a loud right cervical bruit. The patient's heparin infusion was discontinued approximately 6 hours prior to arteriography. Arteriography showed a total occlusion of the internal carotid artery at its origin and a severe stenosis of the external carotid artery at its origin. At the completion of this procedure, the patient was taken to the surgical intensive care unit for routine monitoring, where a follow-up duplex scan was performed. A subsequent physical exam that evening failed to demonstrate the presence of the previously noted right cervical bruit. This is the duplex scan that was performed that afternoon, which shows significant new thrombus formation and a segment that appears to undulate with the pulsatile flow changes in the common. This is the ICA. This is the waveform that was recorded in the common. This is the ICA again. The ICA is clearly occluded. Approximately 18 hours later, a third duplex scan was performed, which shows that the entire right carotid system is now occluded, with propagation of thrombus down the common almost to its origin. This is the internal vessel here. This is a Doppler in the common. This is an image of the external carotid artery, which appears to be occluded at its origin but is patent distally. This is the ICA. Retrograde flow through this branch fills the distal external carotid. At 6-month follow-up, it was learned that the patient had suffered a right hemispheric CVA in the interim that left him with a residual left upper and lower extremity weakness. Duplex scan performed at this time did not demonstrate any appreciable changes from the last study that we performed while he was hospitalized here. Although it is not possible to fix the time of occlusion with 100% certainty, we feel that it is likely that this event occurred either just prior to or during arteriography. The withdrawal of heparin and/or the rapid dehydration associated with contrast administration could easily have precipitated sudden occlusion in this individual who was at increased risk for this type of event. This series of duplex scans demonstrates progressive thrombus formation over a 7-day period. In those patients in whom good visualization is possible, intracarotid thrombus is detectable virtually as it forms. This case also demonstrates that close follow-up by duplex scan is warranted in selected patients and that asymptomatic carotid occlusion is not necessarily a benign event.